Okay. Welcome everyone to this MBA on air webinar. My name is Eduard Tornero. I'm speaking from the Hospital Clinic of Barcelona, and well, it's a great honor to be here as moderator because today we have prepared a webinar that I think it's going to be very interesting. We're going to talk about local antibiotic carriers and its usefulness both in the management and in the prophylaxis of surgical infections. As everybody knows, management and prevention of surgical site infection is nowadays one of the main concerns of any surgeon, but especially in those surgeries that require any type of implant, and an infection, well, can be catastrophic for the patient. I think that today no one disputes that the usefulness of intravenous antibiotic as prophylaxis in preventing this type of infection or as treatment when infection occurs. But beyond the choice of the type of antibiotic, there is increasing evidence that this intravenous antibiotic sometimes has difficulty achieving optimal concentrations in subdermal fat tissues, which is where infection takes place. It's for this reason that in recent years, several strategies have been used to complement this antibiotic prophylaxis, especially in surgeries with a high risk of infections. One of these strategies that has gained popularity in recent years is the use of vancomycin powder as an intrawound prophylaxis. First studies with this technique were promising. However, we have to say that subsequent studies have not turned out to be as good as expected. Probably the rapid disappearance of optimal concentrations of antibiotic with this technique could explain this inconsistent results among different studies. But on the other hand, local antibiotic carriers such as vancomycin impregnated beads of calcium sulfate or polymethyl methacrylate have demonstrated in vitro and in vivo studies very good levels of antibiotic concentration, and always above the mic even 3 months after surgery. That is what we are going to talk about in this session, and that's why we have a very special speaker. Please welcome Dr. Stuart Hirschman from the Massachusetts General Hospital and Harvard Medical School. Good morning in Boston, I think, Dr. Hirschman. Good afternoon here in Barcelona.
Hey, thank you very much, Dr. Tornero, and I appreciate the invitation to talk about this topic. You know, I think that what you just said summarizes the issue very clearly, in that we have a number of different tools available to us today, in addition to intravenous antibiotics, that can really help out in reduction of reducing surgical site infection. And so today, I'm going to share my screen here for a moment.
Yeah, let me a moment, please. Dr. Hirschman.
Yep.
Yeah, as I said, let me introduce the rest of the guests, please.
Sure.
Dr. Hirschman, you know, is a renowned spine surgeon specializing in complex spinal reconstructions. Patients with a spinal deformity that requires surgery usually is a kind of surgery with a long duration, very large incisions, and extensive multi-level instrumentations. And therefore, the risk of surgical site infections is much higher than in other surgeries. And we all know that when an infection occurs, it significantly increases patients' morbidity and cost of care. He's going to talk about a recent paper and probably other papers that he published. And after that, we'll have a roundtable with 3 other guests, all of them with vast experience in their respective fields. First of all, let me introduce Doctora Susana Núñez. Buenas tardes, good afternoon.
Good afternoon.
Doctora Núñez is a spine surgeon at Hospital Universitari Vall d'Hebron in Barcelona. Her department is a national and European reference in spinal surgery, especially in adult spinal deformity. From the same hospital, but from the Department of Infectious Disease, today is also with us Doctora Dolors Rodríguez. Buenas tardes, Dolors. Good afternoon.
Good afternoon. Hi, everyone.
over the last few years, Dr. Ruiz has focused much of her research activity in bone and joint infections, especially maybe in prosthetic joint infection and surgical site infections. And consequently, today we can find a large number of papers in which she's one of the authors, and we can say that, well, she's a reference for all of us. And our last guest comes from the University of Hospital of Siena in Italy. Buonasera, Dr. Carangelo.
Good afternoon. Buonasera.
Dr. Biagio Carangelo is a member of the Department of Neurosurgery, and he has well, long experience in spinal surgery for the treatment of many pathologies, including spinal fractures, spinal deformity, tumors. Well, with all guests introduced, I think it's time to give the floor to our main speaker. I want to remind everyone that you can send any questions you want to the webinar chat, I think, both for our speaker or for the rest of the guests, because we will collect them all, and at the end of the session, we will spend a few minutes trying to solve them all. So now it's time, Dr. Hedgeman, please go ahead when you want.
Great. Thank you, Dr. Tornero. And again, thank you everyone for that introduction and for inviting me today. So as Dr. Tornero mentioned, we're going to be discussing, there we go. Going to be discussing some of my experience regarding vancomycin impregnated calcium sulfate beads in people undergoing thoracolumbar fusion surgery. And one of the reasons that we're discussing this in general, and I should also mention that I'm a paid consultant for biocomposites. So one of the reasons that we're talking about this in general is that, as Dr. Tornero mentioned, you know, the incidence of infections in some of these larger cases is significantly higher than we would like. And there are lots of different reasons that have been hypothesized as why the infection risk is more considerable in this population of patients. Certainly, there's a longer incision. The surgical time is typically much longer for these cases. Most patients who undergo a long thoracolumbar spinal fusion experience higher rates of blood loss and bleeding. And obviously, whenever we're using large amounts of instrumentation, the incidence of infection in theory is increased because of the possibility of biofilm and other sort of issues, such as the fact that the metal is also exposed to the outside air during the wait time until it's implanted. And so studies have been conducted, and they've actually estimated that in long thoracolumbar deformity patients and undergoing surgery, the incidence of infection is estimated to be somewhere around 4 to 6%. And groups have looked at this, and they've kind of determined whether this actually can be mitigated, whether the risk can be sort of lowered at all. And one group out of San Francisco looked at 90-day readmission rates for surgical site infections in adult deformity patients undergoing complex reconstruction. And they found that just by adding local vancomycin powder, they were able to reduce the risk of surgical site infections in these patients. And they actually concluded that for every 100 of these surgeries that were being performed, if you were able to reduce the infection rate, essentially bring it down to a quarter of what it was, you were essentially saving $250,000 US. And so they found that by just adding a little bit of vancomycin powder into the wound, they were able to reduce the surgical site infection rate from around 11% to around 2.5%. And that obviously is a substantial reduction, not only in morbidity, but also from a cost savings perspective. Fred Sweet actually looked at an animal model and tried to determine whether adding 2 grams of vancomycin powder into an instrumented fusion in the thoracic and lumbar spine was able to reduce infection rates. And again, this was done using an animal model, and he was able to reduce the infection rate just by adding vancomycin powder, being used again in conjunction with cephalosporin administered intravenously for pre-op prophylaxis. And he found that the infection rate dropped from 2.5% down to just 0.2%. So really a tremendous reduction. We'll call it a 10-fold reduction in infection rates with the addition of vancomycin powder to the wound. And if you look down here, he actually concluded that the amount of vancomycin that was present in the wound really sort of dropped off dramatically over the first few days. So you can see that just on day 0, there was a substantial concentration of local vancomycin powder in the wound. And then after just one day, it was really just a third of what was initially there previously, half of that from on day 2. And then by the time we get down to day 3, we're looking at around 1/10 of the initial concentration of vancomycin levels that were in the wound. And so we see this drop off, and it sort of raises a couple of questions for us. Primarily, is the vancomycin really providing sustained relief or sustained prevention of infection? And are we able to somehow perhaps do this a little bit better? So other groups have studied using different vehicles to, or I should say different carriers to allow antibiotic administration. And certainly that is not a novel concept. Most of the time when we are discussing this, we've seen it being used, for example, either as a bone void filler, and many of the studies have been done on other locations of the body, not necessarily the spine. And so the first group that we're looking at out of Poland, this first study looked at total joint replacement, specifically in knee arthroplasty. And the second study, which was out of the United States, was looking specifically at foot and ankle work. And so other areas of the body are no stranger to the use of carrier products, such as a calcium carbonate or a calcium sulfate vehicle to help administer and deliver antibiotics. Now, the biocomposites team looked at whether adding antibiotics specifically into a high purity calcium sulfate molecule would be able to elute antibiotics over a prolonged period of time and allow the antibiotic to actually be delivered essentially over a much more prolonged period. So therefore, we're actually kind of keeping the concentration of antibiotics much higher at the local site where we're really concerned about infection. And so in this particular paper, gentamicin, tobramycin, vancomycin, and rifampin were each placed independently into stimulon beads. And again, these are high purity calcium sulfate beads that are able to hold onto these different antibiotics and elute them at a much slower rate, allowing the concentration of antibiotic to stay locally in the wound. And both 3 and 6 millimeter beads were used. And they found that even after 6 weeks, there was still a very reasonable MIC of the antibiotic. So we knew that the antibiotic actually still had some potency left. And we decided to take a look at this after seeing all the success that was written up by other groups in other locations of the body. We decided to take a look at this and say, well, can we use this in the spine? And specifically, can we use this in a population of patients which is known to be relatively high risk for surgical site infections, namely complex spinal patients and adult spinal deformity patients? And so we looked at our previous cohort, which was essentially us using vancomycin powder in all of our long constructs. And we looked at this over a period of about 1.5 years, from January of 2017 to September of 2018. And over that period of time, we had 42 patients who fit the criteria for our study. And 4 of those 42 patients had developed a surgical site infection. And starting in October of 2018, I started using vancomycin impregnated stimulon beads in my long spinal fusion cases. And so we had this sort of natural cohort since nothing else had changed. The only thing that changed in this group were the only thing that changed in these patients were the antibiotic administration system at the end of the case. So vancomycin powder in the first group and stimulon in the second group. And so since October of 2018 and running through March of 2020, we had 53 patients who underwent a complex spinal reconstruction from the thoracic spine down to the pelvis. And in that cohort of patients, we only saw 1 post-op surgical site infection. And interestingly, when we take a look at these infections, we noticed that in the stimulon group, we only saw 1 infection, but it was a gram-negative bug. And in the vancomycin powder group, 3 of these were actually gram-negative as well. And we'll get back to that in a second as to why we think that may be important. But certainly, we saw a significant decrease in our surgical site infections by introducing vancomycin impregnated stimulon beads into our wounds. So our early experience with stimulon we saw essentially a higher rate of postoperative seromas. And I'll say that it's not just stimulon that we started seeing these seromas. It was actually once we started using vancomycin powder. And I'm curious at the end of this talk, I'd like to hear what others on the panel have found, whether they've been seeing increased incidence of postoperative seroma when using vancomycin powder in their wounds. But certainly we know that postoperatively, especially when there's a large dead space that's created in some of these spinal deformity patients, that you're going to get a seroma. That's sort of part and parcel to the procedure. When you're creating this lordotic dead space, you essentially will find that there's going to be fluid that collects. And so our postoperative seroma patients, we started seeing that the seromas were getting a little bit larger just by adding some vancomycin powder into the wound. And we were concerned that certainly, the seromas, while not necessarily dangerous, they can be annoying to both the surgeon and the patient. And we knew that by adding any irritant into the tissue, certainly you can absolutely incite some sort of seroma. We were hoping that when we added stimulon or the calcium sulfate beads that are impregnated with vancomycin powder into the wound, that perhaps we would see maybe even less seroma. But in fact, what we were seeing initially was that the seroma was essentially about the same, maybe even a little bit bigger after adding the calcium sulfate vancomycin impregnated beads into the wound. And so that sort of, again, raised a couple of questions for us and sort of shaped the way that we are now using vancomycin powder and vancomycin impregnated stimulon beads. So what we initially did was we started using a little bit less stimulon. Initially, we were using 20 cc's of stimulon into all of our wounds. And we certainly have seen a significant decrease in the amount of postoperative seromas, or at least clinically significant postoperative seromas in our patients after using less stimulon. And so now we have a little bit of an algorithm based on the size of the wound as to how much stimulon beads we're going to use in our wound. We also decided to start leaving the drain in place a little bit longer. Really, we were taking the drains out on postoperative day number 3, and now we leave our drains in until the patient leaves the hospital. For patients who have a large postoperative seroma, we also consider using an abdominal binder. And certainly if the postoperative seroma is very significant or bothersome, we offer aspirating the fluid either in the office or while the patient is still in the hospital. And unfortunately, when we have, because you do have patients with a molecule that's sticking around for a little bit longer than what we were seeing initially with just vancomycin powder, we may need to consider doing multiple aspirations in certain patients. And I've had to do this in 1 or 2 of my patients over the last couple of years. So getting back to this interesting finding that we saw gram-negative bacteria growing in our wounds, we decided to start changing our protocol a little bit. And so we now actually use gentamicin in the beads as well as vancomycin. And we're hoping to see, we don't have long-term data or actually much data yet, since this was a relatively new addition to our protocol, but we've been getting very good results as far as reduction in infection is concerned with just the vancomycin. And we're now hoping to see similar results in reducing the incidence of gram-negative infections with the addition of gentamicin to the stimulon beads. So looking at our numbers, we were concerned that we didn't see a statistically significant difference between the 2 groups, the vancomycin powder and the stimulon beads. And certainly when you take a look at the numbers, our study was underpowered. And it was underpowered because infection, fortunately, is not a terribly common problem, even in a high-risk patient such as a spinal deformity patient or a complex spinal reconstruction patient. Interestingly, as we noted already, the only infection that we had in our stimulon group was a gram-negative bacteria. And that sort of led to our change in protocol as far as adding gentamicin to the beads. And interestingly, I think perhaps most interestingly, is that 60% of the infections in the vancomycin powder group were also gram-negative infections. And so, while we think of MRSA as being the common bacteria that we worry about, or even MSSA, it may actually be some of the gram-negative or polymicrobial bacteria that might need to be covered for a little bit more broadly in our high-risk patients, such as spinal deformity patients. And so this is something that perhaps we should be focusing a little bit more attention on when we start doing studies. So again, as I mentioned before, we started seeing a larger rate of postoperative seromas when we were using large amounts of stimulon in a relatively smaller wound. And so now we have this algorithm where, depending on the size of the wound, we use a certain amount of stimulon beads. And so, for example, for a long upper thoracic fusion down to the pelvis, we tend to use a 20 cc batch of stimulon, and as the wounds get smaller, we use less volume of beads. And so certainly a standard procedure such as the one on the screen, which is a T10 to pelvis procedure, would get around roughly 10 cc's of stimulon beads. And for smaller, even a single level or two level degenerative procedure in the lumbar spine, including instrumentation, I put 5 cc's of stimulon beads in those wounds. And so I've moved now, it used to be just my high-risk patients that were undergoing a long thoracolumbar fusion were the ones who were receiving stimulon beads into the wound. And now if there's instrumentation in there, I just put stimulon in there as well. I've noticed that, even though the risk of surgical site infections is significantly lower in some of these degen patients, many of those patients, because of medical comorbidities or just the hardware in general, they're also at risk for surgical site infections. And we haven't published our data quite yet, but we've seen a nice drop in our infection rate since using stimulon beads in some of these smaller lumbar degenerative cases as well. As it says on the screen, for 10 cc's of stimulon, I'm now placing 1 gram of vancomycin and 240 milligrams of gentamicin. And again, that's a newer, we'll say, protocol as far as my patients are concerned. Typically, we were just using, or in the study that I initially wrote, it was only 1 gram of vancomycin per 10 cc's of stimulon. And now with the addition of gentamicin, once we saw that our gram-negative bugs were more prominent or more common than we thought, we're hoping to see that there's a similar successful reduction in infections after adding the gram-negative coverage. Once you add your stimulon beads, this is really what 10 cc's looks like. And so you can see that you get nice coverage of not just the hardware, but also it would be able to float around and fill some of the dead space as well. You could theoretically imagine that if this incision were, we'll say, almost twice as long, including an upper thoracic spine, a fusion from the upper thoracic spine down to the pelvis, you would want more coverage, and certainly you would want more beads. Similarly, you can imagine that if you had a smaller wound, then half the volume of these beads is really all that is needed, and you probably don't need much more than that. I do want to point out that contrary to the US, where stimulon is currently used as a bone void filler, in Europe, stimulon is actually the first calcium matrix that actually received approval to be an antibiotic carrier, not only in bone, but also soft tissue. And so while we're using it perhaps in a little bit of an off-label fashion by placing it to fill the dead space here, it is being used to deliver or as a carrier for the antibiotics in bone and soft tissue, and is used in an on-label fashion in Europe. So one of the things that we've sort of wanted to take away from our initial study is where we can kind of go towards the future and try to figure out ways to reduce infection rate even further, and what may be the best avenues to study. And right now, this is just one center, and it's really just my cohort of patients that are undergoing these procedures. And while infection may be a relatively uncommon event, we need much higher numbers in order to actually really sort of discern great information and get great numbers and great data. And so we really do need to study this in multiple different centers and over multiple different surgeons in order to adequately power the study. Again, infection in general, even though it's relatively high in these high-risk patients, the risk and rate of infection is still relatively low. And so we need to really capture the work from others as well in order to kind of really get great data and great numbers to power our studies appropriately. So perhaps looking in the future, what data should we be looking at specifically? And so, these are things that we've kind of tinkered with on our own here before undergoing our initial study, but we looked at bead size, and right now we're using the smallest beads that that are available through the Stimulon drying process. And those beads, I think that they provide much more sort of surface area and coverage as far as the fact that they can get into places that are a little bit smaller. So we've been using the smallest bead size, but that may not be the best model. And so I think that studying the size of the beads may be a new area of interest, and something that we may pursue in the future. I mentioned before that the bead volume, it's sort of a double-edged sword. We want to have great coverage, and it's great to have more beads in there so that you are eluting more antibiotics. But we noticed that when we placed too many beads, we were getting a higher incidence of postoperative seroma. So we found what we believe to be a little bit of the sweet spot, where we have, based on the surface area of the, or I should say the incision length and the surface area of the wound itself, we put in a bead volume that we believe is now appropriate. So for a lower thoracic spine to pelvic fusion, we've been using 10 cc's. For an upper thoracic spine to pelvic fusion, we've been using 20. And for smaller lumbar degen cases alone, we just place 5 cc's of beads, and sometimes less if it's a small wound. As far as antibiotic choice is concerned, I think that gram-negative coverage is really going to be a bit of a game changer for us, and we're hoping to see similar results as far as the reduction in not only infections, but also gram-negative infections moving forward. We do note that complications are going to occur, and certainly the postoperative seroma is an issue, and I think that we've been able to get lucky and mitigate some of that risk by lowering the amount of antibiotic and lowering the amount, or the volume, I should say, of Stimulon beads. We don't know whether long-term we're going to see any sort of risk of pseudoarthrosis. What we do know is that calcium sulfate is used elsewhere within orthopedics, and it's used really to fill not just bone voids, but also, for example, in the use of fractures where bone can actually integrate and replace the calcium sulfate. So we think that the risk of pseudoarthrosis is actually very low. We know that vancomycin powder by itself can actually, or has been reported to potentially reduce the risk or reduce the rate of fusion, but this is not borne out in our data. And we do plan on and are already looking at whether the risk of pseudoarthrosis is higher in patients who have received vancomycin powder, and whether the delivery system actually makes any sort of difference. And lastly, and I'm certain that our friends in the Department of Infectious Diseases will be able to weigh in today, but whether we're really breeding any sort of resistance by introducing larger and perhaps more antibiotics and different types of antibiotics into the wound locally. And personally, I think that this is not going to sort of yield antibiotic resistance per se, because we are keeping it just very local and only using it specifically in patients who have right now a high risk of infection. But as we expand and start to use it perhaps more frequently in the lumbar degenerative cases or in other portions or other parts of the body, we may start to see that we're running the risk of some superbugs. So again, future applications, right now we've only been using Stimulon to study our high-risk thoracolumbar deformity patients and complex spinal reconstruction patients. But perhaps, for example, looking at this also to be used for posterior cervical laminectomy infusions, especially in the setting of trauma, whether a patient who is undergoing a lateral fusion, if there's any sort of role for that, or an ALIF. Now, ALIF and lateral fusions are associated with a much lower rate of surgical site infections. But perhaps if we can eradicate even that 1 in, let's say, 100 cases, I'm sure we would see a significant reduction in not only the cost of healthcare, but in the morbidity of our patients. We can also consider using this in open fractures and, again, high-risk fractures in other fields of orthopedic surgery, for example, where some of those patients may be at risk for postoperative infections just as a result of their injury. So I did want to present a couple of cases, and I think that this not only illustrates sort of how versatile the beads can be, and certainly in sort of the setting of various different pathologies, but it also shows you really kind of what sort of coverage you can get with these beads on X-ray. And so here's the first case is a 72-year-old female who presented with worsening posture and low back pain. And we send all of our patients initially for non-operative treatment. And so she had already failed physical therapy, epidural steroid injections, and some medication. She was a former smoker, and she has a significant past medical history. So she had a previous infection at L4-5, which was treated with IV antibiotics. She had auto-fused her L5-S1 level already. And this patient, unfortunately, was morbidly obese and a Jehovah's Witness. So here we are. We're a bit of a setup here for a very long day in the operating room. And this is a complicated patient with multiple comorbidities. And so you can see here how she stands, and she has just really a minimal degenerative, or I should say asymmetric collapse on the coronal plane. You can see she's already had a total hip performed. But you see that in the sagittal plane, not only is she carrying a little bit more weight than we would like our patients to have, but she has a very, very flat, almost parallel L4 to S1 segment. Her lumbar lordosis is significantly reduced to what it should be. She has a very high pelvic incidence and really should have a correspondingly high amount of lumbar lordosis. She's pitched forward. If you look at her sagittal vertical axis, we're talking about somebody who's around 15 centimeters forward. And looking at her CT scan, you can see here that she had a lot of erosive change at that L4-5 level where she had that previous infection. And you can also see that the L5-S1 level had really completely autofused. And this was suspected that there was probably some sort of infectious etiology going on there as well, which led somewhat to that fusion. You can see the fact that there's air within the L4-5 level, suggesting that the bacteria is no longer present. That's was a finding reported in a number of studies. And you also see that there's calcification of her great vessels anteriorly. So again, this is not necessarily a healthy patient. And so this is a patient who we thought was a great candidate for using Stimulon beads. She's high risk for infection. We actually contemplated putting and ended up putting some Stimulon beads into that L4-5 disc space, especially since we were going to be putting some instrumentation in there as well. And this is what we did for her. We ended up putting a long construct to bring her back. These are her initial post-op x-rays, standing x-rays on post-op day 3. And you can see that we restored her lordosis significantly, but at that L4-5 level, where it was really just kind of a bit of a mess in there, we were able to place a cage, a titanium cage, and pack the space with autograft and Stimulon beads. And this is really kind of giving us a little bit more sort of, I'll say not certainty, but certainly confidence that perhaps if there's any lingering bacteria in there, that maybe we're really eradicating that bacteria or having the best chance of that by placing those beads. And you can see that the Stimulon beads, this is again post-op day 3, you can actually see them on both the AP, you can see them sort of hovering on the outside over here. We just place them right in on top of the wound, on top of the bone graft after we place our bone graft. And again, this is going to be a seroma back here because we've introduced a significant amount of lordosis. And so it's going to fill with fluid. And now our essentially hope is that as the antibiotic elutes out from the Stimulon beads, it actually is able to kind of circulate a little bit in the seroma and really provide a nice amount of inhibitory concentration of antibiotic agent in that fluid collection, which would otherwise be a potential nidus for infection. You can see that we also place a little bit of the Stimulon beads in the suprafascial plane as well. And this hopefully will help mitigate the risk of postoperative superficial wound infections as well. And at our last follow-up, which was, I believe, this is a 6-month post-op X-ray, you could see a nice construct that's holding up, and the patient is in a much more anatomic position. She's much happier. Again, the pain that was present prior to surgery has now dissipated, and it's really just more, again, on the road to recovery. Another case here, this is a 68-year-old female with back pain, leg pain, and worsening posture. And she also, again, went for non-operative treatment first in the form of physical therapy, epidural injections, and medication as well. She's a non-smoker, but she did have a history of osteoporosis. And so for all of these osteoporotic patients, we pre-treat them with 12 weeks of teriparatide at a minimum before we take them to surgery. And so you could see here from her pre-op X-rays that she's really a very sick individual. She's almost cachectic, and really had a very sort of poor metabolic status, as evidenced by the osteoporosis. And certainly when we do nutritional studies on all of these patients, we found that she was malnourished as well. And so we do a preoperative optimization on these patients, again, including teriparatide. We have nutritional supplementation. We actually have these patients seen by registered dietitians, and we make sure that biochemically they're in a much better place preoperatively once they've been optimized. And so this is a lady who really was very high risk for infection, and we were very concerned. And we ultimately performed a posterior spinal fusion on her. You can see here she's again a close-up. You can see she's very kyphotic through the lumbar spine. And we were able to get her optimized to the point where we felt surgery was going to be very safe. And this is actually a 3-month postoperative X-ray, and I believe that she's now around 6 months out. We just recently saw her. I have not updated the films, but she's doing extraordinarily well. She's been able to put on some weight. Her construct has held up very nicely, and fortunately, we have not seen any sort of postoperative infections or hint thereof. And so this was a lady who really we were very concerned about as being very high risk, and she understood that there was a very significant risk for postoperative infection. And I think that the Stimulon and a preoperative optimization protocol were really able to help mitigate some of those infection risks. And then lastly, this is a 58-year-old gentleman with back pain, leg pain, and worsening posture. He has had multiple procedures done, and his procedures really were in the form of uninstrumented fusions. He had a peripheral stimulator placed, a spinal cord stimulator placed by another physician. He then had a spinal cord stimulator removed. He recently quit smoking. So for all intents and purposes, I make all of my patients, all of my fusion patients stop smoking for at least 6 weeks prior to surgery and a minimum of 6 months after surgery. But those patients really are also at risk for infection. And so this is, again, a gentleman who we felt was a significantly higher risk patient. And so we were concerned, especially given his medical history also of depression. He's a very sedentary individual, that perhaps this is someone who would be a setup for infection. And so we took him to the operating room. You could see that he has almost what appears to be a neuromuscular component to his curve. He's imbalanced in both the coronal plane as well as the sagittal plane. You can see the battery pack as well as the peripheral stimulator leads in place. And so we took him for a long thoracolumbar fusion and did a pedicle subtraction osteotomy. And again, for these patients, we do worry, is there perhaps some sort of issue with putting in Stimulon beads or having the calcium sulfate beads as they elute antibiotics, or perhaps just as the calcium sulfate itself dissolves? Is that going to affect our fusion rates? And we have not seen that. We've actually seen solid fusions in almost all of these patients, and we've been very lucky from that perspective. So certainly this is a high-risk patient with a lot of sort of, we had a lot of trepidation as far as what could go wrong with this individual. And so far he has done very well. He, again, is also about 6 months out from surgery. These are his 6-month postoperative x-rays. We're probably about closer to 9 months out now, but he has done very well, and we've been very fortunate with our application of Stimulon beads and the lack of seroma that we've been seeing now that we're using the lower volume concentration. and smaller amounts perhaps of antibiotics as well. So thank you very much for your time and attention. And I'm opening the floor up to Dr. Tornero, and certainly we're happy to answer any questions.
Thank you very much, Dr. Heichmann. It was a brilliant presentation, very, very interesting, very clear. I sincerely think that the use of these carriers can change the paradigm of this type of surgeries. It's true maybe that maybe more prospective and large studies and more experience are necessary to confirm its utility, but without a doubt, this surgical technique could help a lot to solve a serious problem that nowadays we have with this type of surgery. So we realized that I didn't introduce Jonathan Mahoney. Sorry, Jonathan. Maybe you want to be the first one to talk now.
Sorry, for what? For
yes, well, we want to start a round table, and maybe you want to be the first one to participate.
Yeah, sure. Yes. You've caught me on the. You've got me on the spot there. I've just a question really about Mr. Dr. Hirschman, the pseudoarthrosis kind of that you talked about, the potential for pseudoarthrosis. As you say, it's something that's not really been seen in the arthroplasty side, and I would hope that it's not something that we'll see in the spine. But have you seen any kind of heterotopic ossification or any other indications of it in your surgery?
Well, it's thank you for that question. I think that the fact that we are even thinking about pseudoarthrosis, again, it's a theoretical risk that no one has ever really reported on or seen just yet. Whenever we're talking about these long thoracolumbar fusions, pseudoarthrosis is a real concern, and we see that in around 15% of patients, regardless. Whether we'll see more of it or perhaps less of it with the addition of antibiotic impregnated stimulon beads is really an area that we would like to study. I would say that as far as ectopic bone formation is concerned, we can't even say that, because really when we're doing a fusion, that's what we're hoping to see. I'm laying down a ton of autograft, and I'm putting down, throwing everything but the kitchen sink at these things. I do use quite a bit of BMP in some of these complex cases. That's bone morphogenetic protein. And certainly I want to see heterotopic bone growth, all over the dorsal aspect of the spine and in the posterolateral gutters. And we are seeing that. Fortunately, we're seeing that. And I think that it's really a testament to the fact that stimulon does not get in the way of ectopic bone growth and the fusion mass. I think that we have not seen any higher risk so far or higher rate of pseudoarthrosis. We have not seen any higher rate of rod breakage. But this is all, and I'll just say this is by anecdotal report. I have not studied this in detail yet, and I think that that's one of the things that we're currently looking at, and certainly is an area of interest for me and many others.
Thank you.
Oh, please feel free to the other guests to intervene whenever you want.
I'm sorry, go ahead.
Oh, well, as you like. Well, I have two questions, maybe. One, you have already spoke a lot about it, which is shoulder arthrosis, which has always been feared because of those in vitro studies showing that vancomycin could locally be toxic for osteoblasts. So I think this is something you should really focus on. I think the advantage here compared with the powder is that you have osteoconductive substance, which are the beads. And also, I have read a lot about this vancomycin powder thing, but there are no studies reporting on fusion rates, which is something that has always made me a little bit worried about this thing. Why is this a big concern and we are not even reporting it? So I think this is something definitely we should be focusing on. And we usually place the vancomycin powder only on the superficial layer, not near the bone graft. So, but I saw in your presentation, the beads are placed in the deep layer together with the bone graft and everything. And I guess when you use the vancomycin powder, you used to do the same. Is that so?
That is correct. So I placed the majority of both vancomycin. When I was using vancomycin powder, I would place the majority of it subfascial, and I would place a little bit of it suprafascial. I do the same. I do the same thing now when using the Stimulon beads. I place, let's say I'm using a 10 cc kit. I would say I probably use 80 to 90% of it subfascial, and then I place the remaining, we'll call it 10 or 20% of that suprafascial. I think that, again, what I'm trying to minimize is that deep infection. I think that that's really where the danger lies, and I'm trying to mitigate the risk of a surgical site infection, of a deep surgical site infection, by placing it subfascially. Okay.
And then I have also a big question regarding the seromas: is how do you manage when you have a big superficial of the compression or laminectomy, and maybe a dural tear may happen? If you fear there is going to be CCF leakage, are you worried about the seroma? And maybe you say, okay, I'm not going to use this because I'm not going to use vacuum in my drain. So maybe it's a concern for you. And how do you manage that? If you do have a dural tear, or if you have a big decompression, do you put the beads also around, or?
So I have, first of all, actually, this is a good segue because there is a question about placing the beads around the dura, and I'll get to that in a second. But so I have not changed my protocol based on whether there's a durotomy presence, and I have not worried about whether there would be a compressive postoperative seroma in these patients, even in that setting. And so I think that again, while it's a concern, and we certainly are, while we worry, I should say, that if there's a postoperative seroma in the setting of perhaps even an irreparable durotomy, that may change our outcome, but we have not seen that. So what we do is right now we repair our durotomy primarily, and then essentially go along the case as if it never happened, so to speak. At the end of the case, we place our Stimulon beads, and we can place them right on the dura. We have not had a problem with that. Even in a big laminectomy bed, when there's exposed dura, or even in a 3-column osteotomy, like a pedicle subtraction osteotomy, we can drop the beads right in there. They find, the beads are small, and they find their way just based on gravity into the sort of the apex of the lordosis, which is really where your osteotomy was performed. And we have not had any problems as far as radiculitis. We have not had any problems with respect to persistent leaks, and have not had any problems with postoperative seromas that have been compressive. There have been postoperative seromas, and we've had to drain, again, 1 or 2 of them on more than one occasion, but we have not had that be a significant problem. I think leaving the drain in and making sure that we're using an appropriate amount of vancomycin, the actual antibiotic, an appropriate amount of gentamicin, and an appropriate amount, most importantly, the volume of beads. I think that really kind of keeps our risk of seroma pretty low. With respect to the dura, by the way, I have placed the Stimulon beads right onto the dura in an open laminectomy and had no issues and no concerns at all.
Thank you.
Hello, I don't know. I'm Dolors from Barcelona. I'm ID specialist. And first of all, I want to congratulate you for your presentation. I have enjoyed it a lot, Dr. Hirschman. But regarding all these issues, regarding seromas, all of this, as our point of view, you have told that sometimes you keep the drains in place till the patients leave the hospital. For us, for infectious diseases, it seems quite dangerous to leave the drainage so many days, no? So I would recommend, if it's possible, not to leave the drainage, but to aspirate the fluid as you have done in those patients. But once you aspirate the fluid, what do? You send it to the microbiology department for culture, I imagine so, no? Have you had any positive result? Because then, if you have a positive result of the culture, what do you think?
Yeah.
You are in front of an infection? Is a contamination of the culture? How you manage this situation?
No, that's an excellent question and an excellent point. So we always send our aspirate off to the lab, and they have all been sterile seromas. So again, I think that speaks to the sort of the potency of the stimulant B to help sort of keep bacteria out of what otherwise would be a potential nidus for infection. If we found that there were bacteria in the wound, I think we would be taking that patient back to the operating room. You know, I don't like the thought even of a contaminant. You know, contaminant to me is almost an excuse. You know, I think that, you know, when we see contaminant or see bacteria in fluid, that's not a good combination. And so I would be taking that patient back to the operating room, and that would be considered a deep surgical site infection. With regards to the drain, I completely agree with you. I hate leaving the drain in for longer than even just a couple of days, you know. And we actually spoke to our ID folks here because one of the things we wanted to do was leave the IV antibiotics going until we had the drain out, and they really raised hell. You know, they would not let us do it and said, no, the antibiotics need to be stopped after 24 hours. We're breeding resistance, and you know, if you want the antibiotics, you know, essentially to go until the drain comes out, then you need to take the drain out after 24 hours.
Yes, I completely agree with you. And if I don't know, Dr. Tornero, if I can make another question, I think it's okay if I make another question.
Yes, all you want.
Yes, Dr. Hirschman, in 2019, I had the opportunity to be in the international consensus in Philly. And there was one point that it surprised me that in the spine surgery, you were very worried about MRSA infection, and you use vancomycin in case of colonization for prevention. But in the case of amphetamine as the basic prevention antibiotic, but in case of allergy, you only use clindamycin. And we said, no, with Dr. Núñez, that we were there, we said that in Spain, we also use one dose of gentamicin in order to improve protection in front of gram-negative bugs. No, I see that you at the end you have the same problem, no, and you have had infections with gram-negative bacteria, and now you have changed. No, you not only use vancomycin but also gentamicin locally. No. Do you have any problem? Because I think that with vancomycin there is not serum levels detected, no. But I don't know with aminoglycosides you have had any problem with serum levels, no, detected, of if you have any kind of control of this, because you know with levels of blood levels of gentamicin we can have some problems with the patient, even with you have a carrier, a bit that maintain levels during many days, no. Perhaps it can be some problems, and it's all about this. Do you have any experience with this? Do you have any kind of control with these patients?
So I would say that, first of all, I do not have a specific experience. We do not check serum levels of vancomycin or of the gentamicin. What I will tell you, so with respect to the vancomycin, interestingly, you know, that Fred Sweet paper that I discussed, you know, he looked at that specifically and found that vancomycin is such a large molecule that it has actually a very difficult time entering the vasculature and the systemic circulation when applied locally. So whether it be a powder form or in the stimulant beads themselves, as it elutes, it's not going to find its way into the systemic circulation. Gentamicin, on the other hand, that could theoretically, again, I have not studied it, and I don't know anyone who has. And so in theory, it could potentially enter the circulation. So what I will tell you is that in my personal practice, if a patient has reduced renal function, we don't use gentamicin. And that's really just because of theoretical risks. I have no evidence to support one way or the other, but it is a theoretical risk for renal issues. And so, that's something where we would only use vancomycin. Similarly, we've actually talked to our ID folks here about introducing as a preoperative antibiotic, not just a cephalosporin, but like Ancef, but also introducing just one dose of gentamicin as well preoperatively. And it was met with some resistance. And so we're sort of still just back in the, I'll say the dark ages, just using Ancef as our preoperative antibiotics. But I think that certainly it's a wonderful area to study and something that I think merits further investigation, especially in the setting of the fact that we had polymicrobial and gram-negative infections. And so it certainly is a very good question you asked, and something that we would like to study and investigate further.
If I may, I can maybe shed some light on that. I am aware of 2 centers that have measured serum gentamicin levels following the use of gentamicin in Stimulan in arthroplasty and trauma cases. And neither of those centers were able to detect high, or in many cases weren't able to detect any serum gentamicin. And I think one thing that, and we've also done some animal work that's shown that as well. And I think that one explanation for that is that the actual amount of gentamicin that you're releasing on a daily basis is extremely low. You may be putting 240 milligrams in there, but you may only be releasing that over 30 or 60 days. And so you're getting a 30th or a 60th of that amount each day. So it's, and then that's being diluted through the whole body. So it's whilst you get extremely high local concentrations, when it's then diluted and released very slowly, it's extremely low levels.
Yeah, I would agree with everything you just said. I mean, it certainly is a concern. It's a risk, whenever we introduce any sort of antibiotic into a patient with compromised renal function. And again, those patients are the ones that we would start to see the concentration in the serum creep up, because their filtration process is a little bit worse. But it is reassuring to know that the studies that have looked at this have not found it. And I agree that, if you're releasing, we'll call it 4 to 8 milligrams a day locally into the wound bed and not even into the systemic circulation, it would be unlikely to see concentrations which may affect renal function further.
Sorry, Dr. Carangelo, you want to add something?
Thank you. Thank you, Dr. Stewart. Congratulations for your presentation. 2 questions. The first, what do you think about the direct contact about the stimulant and dura mater? Do you think is dangerous? Is a contraindication? What do you think? What is your experience? There is a difference about the cervical side spine or lumbar side spine? Thank you. The first question.
So again, I've not had any issues with contact with the dura at all. I've used it in patients who have had durotomies. I've used it in patients who have not had durotomies. And certainly, when we do a 3-column osteotomy, which I probably do once or twice a month, I sprinkle it right into the wound bed, and it finds its way into that maximally lordotic area. So it's sitting all over the dura, right up against the roots. And these are roots that are probably compromised anyway. And we have fortunately not seen any problems with it. So I do not worry about placing it directly onto the dura. I do not worry about that as an issue at all. In the cervical spine, I worry slightly more only because the spaces are much smaller. As you alluded to, in the lumbar spine, you have a little bit more room, wiggle room, so to speak. And so if there's, for example, if I do a laminectomy infusion in the cervical spine and I use the smallest beads, the smallest beads can actually find their way into the spinal canal a little bit. And I do worry that it would almost act like a calcified disc herniation pressing it up against the nerve root. And so, believe it or not, actually in the cervical spine, I typically use larger beads. It sounds almost counterintuitive, but I do that because I'm concerned that if the beads were to find their way into the canal, I want to make sure that they don't find their way into the foramen. Again, I'm not concerned per se about the beads sitting on the dura, but I am concerned about compressive lesion acting almost like a calcified disc herniation.
Okay, thank you. Thank you. The second question: what do you think about the use of stimulant in COVID era, in era COVID? What do you think?
Yeah, that's a great question. I think that right now, viruses seem to be sort of on everyone's mind, and it's almost as if we're forgetting about bacteria. And as far as the spine is concerned and surgical site infections, we don't see viruses as being an infectious sort of etiology, but we see bacteria as being really a source of morbidity, mortality, and sort of a much greater concern from a cost and healthcare cost perspective. So I think that I almost sort of separate the two. I think that it's great that people are washing their hands more frequently and that we're disinfecting and cleaning surfaces a little bit more regularly. But I think it's important that we don't forget about what I believe to be the true sort of pathologic agents as far as surgical site infections is concerned. And we start, really kind of keeping a close eye on our infection rates. I think that, some of the protocols regarding cleaning objects now, perhaps they've become a little bit better. We may see a reduction in surgical site infections as a result. But I don't think that COVID per se has much of an influence on whether we should be using antibiotic impregnated beads to help reduce surgical site infections.
Thank you. Thank you. Thank you.
I don't know if someone wants to have another opinion, wants to do another question. We have one question from the audience. Everybody was a little bit worried about placing the beads around the dura, but I think this question was already answered. So maybe it's the time to finish this webinar. I hope everyone enjoyed it as much as we did. I'm sure that we'll continue to hear about the benefits of this technique over the next few years. Allow me to say goodbye to all our guests. Thank you very much, Toulouse. Thank you very much, Susana. Thank you very much, Jonathan. Thank you, Dr. Biagio Carangelo. And of course, thank you very, very much to our special thanks to our speaker, Dr. Hirschman. Thank you. Thank you very much.
Thank you, everyone. And thank you for your time and attention, and stay safe. And I hope to see you all soon.
Thank you.
Thank you very much.
Thank you very much. Thank you.
Thank you all. Thanks.
Thank you.
Thank you all.
Thank you, everybody.
Thank you to everyone. Thank you.
Thank you.
Thank you.